All right, so today I'll be talking about the management of multiple sclerosis-related neurogenic bladder symptoms. The objectives for today are to review the diagnostic criteria and clinical presentations of MS, to understand the pathophysiology of bladder function associated with MS, to review the treatment goals and modalities available for MS patients who have neurogenic bladder, and to gain an overall urological management approach for these patients. So multiple sclerosis is an autoimmune disease, and it attacks the myelin sheath surrounding the axons of the neurons throughout the central nervous system. This decreases saltatory conduction and conduction velocity of these nerves. The lesions or plaques can range in size from 1 millimeter to 4 centimeters, and they can be scattered throughout the CNS in the white matter. This can produce a variety of symptoms, including muscle weakness, visual disturbances, because it can affect the optic nerve, sensory aberrations, cognitive decline, and lower urinary tract symptoms. The exact cause of MS is still unknown, but it's thought to be a combination of predisposing genetic factors and some environmental triggers. Canada actually has one of the highest rates of MS in the world. Estimated that 100,000 patients are affected in Canada, are living with MS, roughly 1 in every 340. It is more predisposed to females, and the age of onset ranges between 15 and 40 years. The majority of patients are diagnosed in their 30s. There is a need for urological care, obviously, in these patients. Urinary symptoms are directly related to their level of disability, and this is primarily affecting people in the prime of life in many ways, in their 30s, when they should be having high work productivity, self-sufficiency, self-esteem, personal relationships, professional relationships. This is a time that we really need to work to preserve as much function as possible for these patients to improve their quality of life. 65% of patients, this was a survey from the North American Research Committee, reported moderate to severe urological symptoms. 80% reported any degree of urge-related incontinence, and only a third had seen a healthcare provider within the last year to address these urine-specific symptoms. And we also know that anticipatory medical management can help prevent complications of neurogenic bladder for these patients. So this is an important area that I think we all need to be aware of. So there are 4 distinct clinical courses of MS. The first is relapsing remitting, which is in the top left corner. It's the most common course seen. It has a series of unpredictable attacks which may or may not leave permanent deficits, followed by periods of remission. So as you can see, the baseline can go back to normal, or it can start to shift upwards into increasing disability. The second most common is primary progressive, where you simply see a steady decline in function without these attacks. Secondary progressive MS occurs in 50% of patients who have relapsing remitting. So they start with a relapsing remitting course, and then they suddenly begin to have decline in their function without these periods of attacks. And this can often occur roughly 10 years after their initial diagnosis. And progressive relapsing is the most severe form. It occurs in 15% of patients, and essentially these patients have a decline in function since the onset of their diagnosis with superimposed attacks. So MS diagnosis generally presents with some acute neurological decline. OAB symptoms can be seen early on, and a small percentage of patients with OAB may have undiagnosed MS. Suspicion of MS should be raised in a young patient with new diagnosis of OAB or new onset retention, who also has some sort of other neurological symptom complex like progressive vision abnormalities, muscle weakness, numbness, or paresthesias. The diagnosis is, made by a neurologist by the McDonald criteria, which is a combination of their clinical exacerbations as well as lesions that are seen on imaging, primarily MRI. And a referral to a neurologist should be initiated if you're suspecting the patient may have MS. If you have a high degree of suspicion, you could go forward and order the brain and spinal MRI, but really that can be left up to the neurologist. So to dive into the neuro-pathophysiology of MS, so the location of the MS lesions affects the type and severity of the urinary symptoms. As we know, normal storage of urine begins with sensation in the bladder. The A delta fibers sense the bladder stretch. The C fibers sense pain or irritants or temperature changes in the bladder. These are carried through the pelvic, hypogastric, and pudendal nerves to the lumbosacral spinal cord. Then it's relayed to the cortex, midbrain, periaqueductal gray matter. The pontine micturition center is really the switch between filling and storage. And when emptying is triggered, there's three main efferent pathways. The primary one for emptying is your parasympathetic pathway, travels primarily through your pelvic nerves, stimulates detrusor contraction, and relaxes the sphincter. The sympathetic pathway primarily travels through the hypogastric nerves as well as the pelvic nerves. It does the opposite, so it would promote bladder storage, stimulating detrusor relaxation and contraction of the sphincter. And then finally, you have your Onuf's nucleus in the sacrospinal cord and the pudendal nerve, S2, 3, 4, which control the external sphincter voluntarily. So the location of the demyelinating lesions will determine the properties of the bladder. If there are cortical lesions, you often have patients with cognitive impairment and detrusor overactivity primarily. If the lesions are in the cerebellum or pons, it depends really specifically where they're located. You can have detrusor overactivity or even detrusor areflexia. Lesions in the high spinal cord, cervical spine, again, you see detrusor overactivity. You can also see problems with coordination of the sphincter with detrusor external sphincter dyssynergia and as well as the smooth sphincter. Lesions in the T&L spine, again, have DESD and detrusor overactivity. And finally, the sacral spinal cord, which is not commonly affected by MS, but if that is the case, those patients have detrusor areflexia. Of note, overall sensation is generally intact for these patients. Questionnaires, I just wanted to touch on them. There are a couple neurogenic-based questionnaires. The first is the Actionable Bladder Symptom Screening Tool. This is actually for neurologists. It's a 17-item score that they use to assess their patients and decide if they would benefit from a urological referral for more precise management of their bladder. The Neurogenic Bladder Symptom Score is a 22-item questionnaire for patients to report their severity of symptoms, their urine-specific quality of life. It's been validated in MS, spinal cord injury, and congenital neurogenic bladder. And then you have the general incontinence questionnaires, like the ICIQ, IIQ, and UDI, which are often used in our urologic clinics. So for investigations, seeing a patient with MS, generally history physical. Avoiding diary is really beneficial in these patients, ideally a 3-day diary. Questionnaire of your choice. Urinalysis and urine culture, often they're on immunosuppressive medications. A PVR is helpful if the patients have any symptoms of incomplete emptying or obstructive voiding symptoms. Upper tract imaging and urodynamics, specifically if they have a symptomatic elevated PVR, recurrent UTIs, hematuria, or progressive or refractory incontinence, and then as well renal function testing. There's no CUA, AUA, EAU guidelines about when to order urodynamics in the MS population specifically. All I could find was a UK best practice consensus statement that said that urodynamics are not always required before initiating treatment in these patients, which makes sense. The incidence and specific urodynamic findings in MS are well established in the literature. The majority of them have neurogenic detrusor overactivity without evidence of obstruction. A quarter have DO with some detrusor sphincter dyssynergia, 20% have detrusor underactivity, and 10% actually have no findings. And despite the rate of DSD in this population, upper tract involvement in progressive renal disease is actually quite uncommon, which is interesting compared to the spinal cord patients. So treatment goals for MS patients can be classified into two general themes. The first is safety issues, such as preventing urinary tract infections, episodes of urosepsis, upper tract damage. And the second is quality of life issues, managing their lower urinary tract symptoms and doing our best to help them achieve continence. As the disease progresses, patients do need to be reassessed, reevaluated. Their treatment strategies may change. And caution should be exercised in these patients in recommending any sort of irreversible treatment options because a significant portion of these patients will have a change in their neurological lesions, a change in their bladder function, and that can affect their treatment. So classic treatment approach: failure to store, failure to empty, or both. It's really the question you're trying to answer on your history and whatever investigations you're ordering. I'm going to start with failure to store. Conservative treatment, which you learn to rattle off multiple times as you're studying for your Royal College exam. Behavioral modifications are always the first thing: fluid restriction, decreasing your bladder irritants, timed voiding, weight loss, smoking cessation, treating constipation. And pelvic floor physiotherapy was actually a randomized control trial in the MS population looking at pelvic floor physiotherapy and found that it did decrease the number of incontinence episodes overall. This was after about 6 weeks of treatment. And when combined with biofeedback, it decreased incontinence in up to 70% of patients. Next, moving into medications. Anticholinergics medication we're all familiar with. It is approved for non-neurogenic and neurogenic detrusor overactivity. Urodynamics data has shown in the neurogenic population that anticholinergics can improve bladder capacity, and patients will have a higher volume at their first contraction. There was a large meta-analysis done in neurogenic patients, 16 randomized control trials, that found as well that they were associated with an increased patient impression of improvement. Extended release forms are often used due to fewer side effects. It's important to obtain a PVR in these patients to monitor any incomplete emptying as their bladder function can change, and to be aware of the cognitive side effects, especially in patients who have predominant brain lesions. Mirabegron, the beta-3 adrenergic receptor agonist, causes relaxation of the detrusor muscle. It has been approved in non-neurogenic detrusor overactivity from large trials that have shown that it decreases frequency, urgency, and incontinence episodes. It is currently in off-label use in the neurogenic population, but it is frequently used and often in combination with anticholinergics. It offers a different and often more favorable side effect profile than anticholinergics. And Dr. Kavanaugh informed me that there is currently a validation study in the neurogenic population that's happening now. Which leads us to Botox. So onabotulinum toxin A injections into the detrusor muscle. They've been approved for neurogenic detrusor overactivity since year 2000. It was initially in the spinal cord injury patients. And since then, its indications have vastly grown to include other neurogenic diagnoses, including MS, as well as the non-neurogenic refractory OAB population. The mechanism of action, just to review, is it cleaves the snare proteins which prevent the docking of these acetylcholine-filled vesicles to the presynaptic membrane. You can't release acetylcholine into the synaptic cleft, therefore your motor end plate is essentially paralyzed. This was the first major study published in 2011, specifically looking at Botox in a neurogenic population. It had 275 patients, roughly 50-50 split between spinal cord injury and MS. These patients had to have at least 14 episodes of incontinence per week, so they were quite significant. And they were randomized to Botox 200 units versus 300 units versus placebo injections. Their results actually showed that in this patient population, the baseline number of episodes of incontinence per week was 33.5, and it was similar across all groups. And at 6 weeks post-injection, the Botox groups had 20 fewer incontinence episodes per week. On urodynamics, they also showed improvement in bladder capacity and decrease in maximum detrusor pressure during the first involuntary detrusor contraction. Importantly, quality of life was significantly better in the Botox groups compared to the placebo, and it didn't matter if they had MS or spinal cord injury. There were no benefits to 300 units over 200 units, and the 300 unit group had more urinary retention. The most frequent adverse events from Botox are UTI and urinary retention, but overall this is a well-tolerated and minimally invasive treatment for these patients. This was the second quite pivotal phase 3 study that occurred in these patients in 2013. It was essentially the exact same group, but 700 patients, 50-50 MS and spinal cord injury, at least 14 episodes of incontinence per week, randomized to the same treatment options that were discussed. And they also wanted to look at concurrent use of anticholinergics to see if that affected the outcomes of Botox, as these patients are often on those medications as well. So again, their results showed about 20 fewer episodes of incontinence per week in the 200 and 300 unit Botox groups. And it was the same benefit. Didn't matter if the patients were on anticholinergics at the same time or not, and the 300 unit group didn't offer any further benefit. As well, they confirmed that these patients had significantly improved quality of life, and the same most common adverse effects were UTI and retention.
Well, you know what happens if you follow them beyond that 12 to 13 week period? Always graphs are 3-month follow-up only. How does it sustain for how long?
Yeah, they didn't report on it. They did say that the average length of treatment effect was like 47 months. 47 weeks. 47 weeks. But they didn't say that it made a difference with 300 units.
We put 6 to 9 months, and for high pressure teachers of rep to be see if they get shot in 6 months.
How much is the 200 units?
It depends how you formulate it. Typically, it's in 20 cc's.
But then how much does it cost?
Yeah.
About $800
Plus the needles. But it's covered in BC for MS patients. It's not
That's covered by the Senate plan or by the pharmacare company.
we have to write a special authority, but it's covered.
It's covered by the hospital insurance. Only the hospital. It's pretty cost effective. If you look at
Just to touch base on Nocturia, Nocturia can have a significant impact on quality of life for patients with MS. It's been shown in a study by Brown to produce disruptions and loss of daily activities. Desmopressin is the synthetic ADH analog, and situational use in MS has been supported by randomized control trials. They have shown in this population a decrease in Nocturia episodes of 0.5 to 1.5 episodes per night, and an increase in sleep by a mean of 2 hours. A high bladder capacity may predict better outcomes, as obviously it's promoting storage of urine overnight. To touch on cannabis and marijuana in this population, there was actually a CAMS-LUTS RCT looking at the effect of cannabis on urge incontinence in MS. It was a multi-center randomized placebo-controlled trial. It started with 500 patients who were randomized to either cannabis, delta-9 THC, which is a derivative, or placebo. About half the patients had sufficient data for their analysis. And they did find some decreased rates of incontinence, 38% for cannabis, 33% decrease for delta-9 THC, and 18% for placebo. But there weren't any objective changes in urodynamics, and they didn't collect quality of life data. So there's really no extensive validation trials. It's not currently approved for this indication, but just to be aware that it's been looked into, at least initially. So posterior tibial nerve stimulation is a minimally invasive technique. It's used to treat OAB, refractory OAB, by placing a small gauge needle near the posterior tibial nerve, and it's been shown to be effective for refractory OAB when patients have usually 12 weekly sessions of 30 minutes each. The largest individual prospective series of this treatment included 83 patients with MS and LUTS, which were refractory to at least 2 anticholinergic medications. And of those patients, the results were actually quite good. 89% experienced a 50% or greater improvement in symptoms, which was sustained for 2 years. They needed an average maintenance session once every 3 weeks. As well, there was significant improvement over those 2 years in patient perception of their bladder condition and their global quality of life. It's been proposed in the literature that it may be more cost-effective than Botox or augmentation cystoplasty or urinary diversion, but there's been no formal cost analysis of this treatment. In Canada, it is available in Vancouver as well as in Ontario. Overall, there's a limited use in the MS population. A lot of these patients don't live in Vancouver, and that's a quite long treatment course to commit to moving to Vancouver for. So, sacral neuromodulation is an implantable system consisting of electrodes that are placed parallel to the dorsal S3 nerve root. It's similar in concept to PTNS, where it's thought to modulate different pathways of the ascending and descending CNS pathways to promote urine storage. It is an established third-line therapy for refractory OAB in the non-neurogenic population, but there's very few studies that look at its role in MS, small numbers, and limited quality of evidence, and ultimately the battery is a contraindication to MRI. So these patients, it really hasn't been shown to be used widely, as MRI is their main imaging modality for diagnosis and also to follow their exacerbations and any progression.
So is that done anywhere in Vancouver, or is it go to Edmonton for these facilities and we don't have coverage?
So moving on to failure to empty. So if patients have primarily failure to empty, which is not the majority of MS patients, but certainly about a third of them can have this problem, catheterization versus intrasphincteric Botox injections for DSD versus surgery, these are the three main treatment options that we have. CIC is going to be the first-line staple treatment for the MS patient. There are unique challenges with CIC in this population. They have issues with dexterity, visual acuity, tremor, rigidity, cognitive function. But if the patient can be capable of this, this is often the best way to go. If the patient has an MS exacerbation while they're on CIC, you can bridge them with a urethral catheter or a suprapubic tube until they return to their baseline function and can safely resume CIC. If the patient looks like they need a long-term catheter, it's highly recommended that you place a suprapubic tube, as chronic urethral catheterization is strongly discouraged in this population, where they can have very bad urethral erosion. Botox for DSD, so 100 units of Botox injected into the sphincter. It's been looked at since 1988, primarily in the spinal cord injury population with DESD. Data specific to MS is quite limited. These studies do suggest that these patients can have a benefit that lasts anywhere from 2 to 13 months. There was a recent Cochrane meta-analysis of 4 randomized trials looking at Botox for DESD in the neurogenic population. It can improve PVR and voiding pressures, but the general meta-analysis did have a lot of heterogeneity and bias and inconsistent descriptions of their outcomes. In general, it's not really performed for MS patients. It's more for the high spinal cord injury patients who have very distinct DESD. But it is an option. And then finally, surgery. It's becoming less and less common due to the success primarily of Botox in treatment of refractory neurogenic DO. It is indicated if patients are refractory to all of those treatments. They have a low capacity, poor compliant bladder, upper tract compromise, chronic incontinence, recurrent episodes of urosepsis. The options are urinary diversion or augmentation cystoplasty with a continent stoma. However, the continent stoma would only be recommended in rare cases, as these patients likely will have decline in their hand function, and then you've got another problem to fix. So most of these patients, if they are going to be diverted, will simply have an incontinent stoma. So just to summarize the treatment approach, again, looking at failure to store, failure to empty, MS patients can have a combination of these, and often you have to treat with both sides of the diagram. But as we talked about, first line for failure to store is your behavioral modification and physio. Second line are your medications. Third line is Botox, and then possibly a role for peripheral tibial nerve stimulation. Failure to empty are their 3 things: CIC, suprapubic tube, and then finally surgery. My overall conclusions from reading about this topic is that MS neurogenic bladder symptoms are very common, and they have a major impact on quality of life and disability for these patients in an otherwise fairly healthy young population. It's an evolving and unpredictable disease. It requires proper follow-up and reevaluation of their bladder management. And the urologist does play a large role in determining these patients' quality of life as their disease progresses. Yeah, Dr. Patterson?
I think you have to look at the socioeconomic circumstances of the patient population,
Mm-hmm.
and I think things would touch in on that because my experience with these patients is that they don't have an extended plan.
Mm-hmm.
Our pharmacare program in BC is in COVID era in terms of thinking that oxybutynin can treat everything, and any new drug that's extended release, they block because they're trying to control the budget. And you've got the Vesicare is generic now, but even getting pharmacare to cover that is pulling teeth. And the other thing is so a lot of these people don't have good finances, and so they're the urologists really have to do a lot of work to advocate for these patients and try and get access to these anticholinergics. And God help if you can get Neuro-pathophysiology covered by pharmacare. It's near impossible. I don't think anybody's had any success with that. And we've had meetings with pharmacare. Second issue is that the potential for drug-drug interactions is that you write a prescription for a patient for say phobias, and they're on another medication, and next thing you know, the pharmacist is saying, well, there's a drug-drug interaction, and then you have to throw that one out and you're on to the next one. And so you get into this pattern of trying other drugs, but they often they don't there's other drug interactions with other medications that they have for MS that are a real problem. And then the third issue is that early on, like luckily Alex is here and Irk is around and Brian, etc. But in residential care with all of these MS patients who are quite debilitated, there was this pattern in BC of leaving a urethral catheter. And now, and suprapubic tube is a bad word, and it was just rampant. And so we had to fight against this sort of mentality that just leave the urethral catheters. We had huge problems with urethral erosion. You don't see that now because in the residential care, because we've done outreach programs with the docs that work in residential care, we're getting a lot more SP tubes in. And Alex is sending a huge number of patients in for SP tubes because it's preventing long-term consequences of chronic urethral catheterization in this patient population who often can't, they're asensate or they have cognitive impairment and they have inadequate family structure to advocate for themselves.
Ask you if you want to use slide deck. But as a follow-on to that, with Rebecca has so many drug-drug interactions. How you're going to get calls all the time from the pharmacy on it. People who have a lot of experience with Rebecca, do you have to actually pay attention to those drug-drug interactions? Do you have to discontinue clinically?
The one that I run into often is metoprolol, and it won't do general CPG right to call that. I just don't use it in this population ever because it just won't get covered. They never have financial needs. My experience when I first got here, I was getting pushed back on every best care special authority that I put through, and now I don't know if they just see my name, but they just stopped complaining because I would just lie after lie. So they tried 15 drugs until they finally approved it. So now the Vesicare seems to sail through, and that's my first line if they want oral medication. But I have a low threshold in this population that go directly to Botox. There's a couple interesting things I think about MS. Like one thing that you touched on is that the female incidence is much higher than the male incidence. And we know from our spinal cord injured population that those young males are usually the ones with this high pressure uterus overactivity. They have DESD that's like iron. Trying to get a flexible scope through their sphincter is like close to impossible sometimes. And you see that with catheters as well. Because this happens in females, they don't have the outlet resistance and they probably don't get those super high pressure uterus overactivity events. What they get is incontinence. So when you're trying to determine like this is a patient actually usually the incontinence is the factor that you break up. And there was a study that came out of Houston shortly before I arrived there that looked at the incidence of upper tract abnormalities in MS, and it this really seems to be an incontinence problem.
Mhm.
That's usually a patient here. And my approach is usually like I think almost everybody that comes in with incontinence and just do the urodynamics on, certainly everybody, even if they have really minimal complaints, if they're wheelchair bound and MS, urodynamics, and if they're a male with MS, for sure urodynamics.
Perfect. Dr. Mason?
What, from you're the most updated on this, what do we need to be telling our patients about anticholinergic exposure and the risk of long-term cognitive decline?
I think what I've read is that you're mostly looking at patients who already have like some sort of pre-existing cognitive issue, are going to be at the highest risk of developing further cognitive decline. That would be what I've found out. I don't know percentages.
So I think the best study available for dementia and anticholinergic is this trial in 2015 that came out of a care center. They looked at anticholinergic effects. So it wasn't specifically bladder anticholinergics, but it was any medication with an anticholinergic side effect. And they found there's an odds ratio of about 1.5 for developing Alzheimer's with 2 years of standard dose. So the equivalent of Vesicare 5 milligrams or oxybutynin 5 milligrams twice daily, about a 1.5 odds ratio. So not a huge increase, but enough of an increase that it really raises your eyebrows.
Mhm.
I think we'll probably continue to see that premise develop. We applied for funding for Vesicare and Tobias and Urologic to see if there was dementia impact between population database and sales controls and funding. Not interested in funding that at all.
Mm-hmm.
The jury's still out.
What's your trigger for actually starting an investigation for MS in a young patient who presents with overactive bladder? What about all these kids with dysfunctional voiding? They grow up to have MS. But you see a lot of patients with LUTs, right? In
Yeah.
general urology, urology. Some of them have MS that hasn't been diagnosed.
Mm-hmm.
When do you pull the pin and send them to a neurologist?
From what I read is if they have any other neurological findings. They're saying, oh yeah, my vision's really gotten bad last year, or having some tingling or weakness. If there's any other kind of sniff of a neurologic problem, then that's what I've read about.
So if they have diffuse overactivity documented on a CMG and no other reason for that and no additional neurological symptoms, that's okay? Is what is it, 5-10% of patients with MS present with neurologic symptoms?
Mm-hmm.
Something like that? Is that
Yeah.
used to be that?
Yeah.
What do you think about that?
You know, it's a great question.
Yeah.
The group that really stands
Finally.
the group that it's been 10 years. The group that stands out are these young women that come in with incredibly bad incontinence for no good reason. And it's not something that they've grown up with, like the gallbladder dysfunction group, but sudden onset or relatively low onset.
What's the benefit of labeling them at that time versus in 2 years' time when they manifest? Is any treatments?
I don't know
Yeah,
enough about the
yeah.
disease, but are there some biological therapies now?
Nothing really effective. So yeah, that's a great point. So I have a few patients that have incredibly bad symptoms, super high pressure features or overactivity, and I just get really excited about sending them to an office. And it's like, finally, I got one. It's a win. I've never won. I used to order the MRI, and I never saw plaques. So I've got probably 5 or 6 that fall into that group in the last couple of years. The yield is pretty low. I send them still to meet with the neurologist, but I stopped ordering the studies as a result. I don't know. Jenny sees a lot of MS patients, and she might have had a different experience, but I'm just not really finding it. I just refer them.
The residents, when they rotate through clinics, and they're doing avoiding dysfunction, or avoiding patient, invariably they don't ask about gastrointestinal, they don't ask about neurologic. And so when they're meeting with the staff, they said, well, we need neurologic. We've got to be asked.
Mm-hmm.
It's going to be a rare bird, but you're going to pick it up.
for sure.
I think there is overlap in the population as well, especially the new presentation of MS with dysfunctional voiding, and I suspect that's why the physio makes a difference in the study that you presented.
Mhm.
I think that's a great outlet, and I really drag my heels in this patient population for starting anything at all, especially the oral therapy. If they can do something with their diet, I think that's an underrepresented treatment option. As soon as they get some neurologic diagnosis for them.
Yes.
The first window I set by just moving them along the process. So I get them to come back at 6 months if they're still controlled, 7 months, 8 months. Once we hit the window, then I have it on the wrong side of that window. What I'd like to see is that their symptoms come back about a month before the injection. This is a good one.
Good, well,
Great.
thank you.
Thanks,
Nice to
everybody.
know.
Appreciate it.